So, good morning all. Good evening all. And it's very hectic day, so keep up tongue slip. It's our case meet 37, and as usual, we are meeting on every Friday 8 o'clock. Our celebration of our platinum jubilee year. With that, we have silver jubilee year of our city branch also. So we are conducting these case meets weekly. And now today's stalwarts are Dr. Lipika ma'am. She is our professor at Topiwala Nair National Medical College and Indiavel Nair Hospital. She is very humble in nature. And she accepted very shortly that we will do 2 cases, such in not one. So first one is this topic is Cathlab anesthesia, standby and beyond. Our junior also and my colleague Dr. Rameshwar is presenting this case meet with ma'am, and her colleague Dr. Tejaswini, senior anesthesia registrar, she is also joining with him. So ma'am is a professor TNMC and BUL Hospital. She is also past president of ISM Mumbai. Very humble lady, I can say. And Rameshwar is associate professor at Department of Anesthesia at TNMC and BUL Hospital, and her area of interest of pediatric anesthesia. With them, Dr. Tejaswani, she is senior registrar in Department of Anesthesiology. So, Rameshwar, it's your turn now. You can start your share the screen.
Yeah. Good evening. First of all, I thank my colleague and my senior, Dr. Sachin, and ISA Nanded branch secretary for giving me this opportunity, and also Dr. Prahlad, who is the president ISA Nanded branch. So with that, so today's evening, we have divided the talk between us so that it will prevent the monotony of the non-operating room anesthesia, and so we decided to break the topic, and then we can share. So the first thing I want to continue is from the so we as anesthesiologists are very comfortable in sitting our operation theater and enjoying our daily anesthetizing the cases, and so when we are dealing with such a non-operating room anesthesia like Cathlab, where we have to, as shown in this cartoon, we can see in the OT we are very comfortable, and in places where the OT atmosphere is unfamiliar, we are always outstanding. And also our presence is required in outstanding situations. So when we are called in a cath lab for certain things, then it is always a outstanding performance and outstanding things we have to face and we have to execute. So when we step out of comfort zone of operation theater and go to the non-operating room anesthesia scenarios like a cath lab, it's always a dilemma. So cath lab is first, the cath procedure was performed. If we go into the history of cath lab, the first cath procedure was performed around 1929 by this Werner Forsman, who himself done anticubital vein cannulation, and we can see as attached this X-ray picture. He himself done a cath study on himself. So that is how as simple as it was when they invented this. But when we visit present day cath lab, we see such a scenario where we don't know where is our space, where is our colleague cardiology space, who is where, who is the technician, who is the cardiologist, who is the nurse. So most of the cath lab setups looks like this. So this is what our cath lab looks. So I can this is a clip from our cath lab where we are having cath lab. So can I this is actually a video. So I think I have to exit and then I can share. So this is the control panel, and the previous slide was having the actually the procedure room with the fluoroscopy and patient procedure table. There you can see the anesthesia uh, anesthesia machine, dye injecting equipment. So it is basically, I want to convey that cath lab is a very busy room with lots of equipments, monitor screens, injecting equipments, defibrillator, and the monitoring screen, the giant fluoroscopic machine, and on to add to top of that, somebody the temperatures required to be kept at a very low, so to prevent a warming of those equipments. And somebody is outside at control panel, and they are giving instructions, take this view and that view. So we get, the it's a very busy atmosphere. So when we, as far as the anesthesia challenges of a cath lab procedures are concerned, it is a non-operating room anesthesia. We are familiar with other places like endoscopies and this ECTs and CT, MRI. So similar at when we visit this cath lab, we are always getting ourselves to acquaint with the environment of the cath lab. And usually the population of the patients who undergo the cath procedures is a high risk population. They themselves have a significant cardiac disease. And the nature of the procedure is always a life-saving or life increasing, or something heroic things are, or something very uh, the thing that intervention is going to make a real difference to the patient's heart disease. And yeah, and the environment is challenging in terms of just I showed you the atmosphere, which is a very cluttered one. So we have to take into account of, we have to make ourselves comfortable with the environment. We have to understand the pathophysiology, what procedure. So personal contact with the uh, we have to discuss these things, what procedure by what route, and all these things we have to consult to the cardiologist. Then we have to really see the patient, his disease pathophysiology, and get acquainted with all this. So cath lab, when we visit cath lab, we have to really look for what is useful to us in the form of source of oxygen or anesthesia machine, what emergency medications and anesthetic medications are available in the cath lab. We have to really check for airway equipments available, look for the defibrillator, get it acquainted, because not all cath labs or not all places have the same type of defibrillator. So, and this is the place where we really can land up in a situation where we may need to use defibrillator in a reality. So we have to get acquainted with this. Then due to the fluoroscopic machine, the access to the patient is a very limited, which warrants us to use, long intravenous tubing extensions, and our breathing circuits also have to be very long, and the monitoring which we have to set up is also needs to be long. So all these makes us we have to really look, because whatever comes in our hand, we cannot keep on using it. We have to really put our mind how the procedure, what duration procedure, in what type of patient, what is the access, and what is the monitoring needed, what will be the hemodynamic status of the patient before, during, and after the procedure. Is there any concerns related to all these equipments available, if they are there, or are they useful and can they be used, that we have to really look for. So as I told, the patient population coming to the cath lab is from the simple diagnostic procedure like Cath studies in a complex congenital diseases where you can face neonates or children's or very old patients where they can be coming for permanent pacemaker implantation or implantable defibrillators or uh, some this wall replacements or valvotomies where you can have a really very sick, critically ill patients coming to that cath lab. So, uh, so again, this cath lab environment where a lot of fluoroscopy is used, we have to keep ourselves protected at all the time. So from this slide, we can take, this is the amount of safety gear who are using regular cath lab, who are taking regular cath lab cases in their practice. They have to really think of their safety first. And here you can see we have to wear a lead apron, thyroid shield, the lid cap. We have to protect our eyes. Also, those who are working very close to the fluoroscopic machines like cardiologists or technicians or staffs who are helping to the cardiologist. And if we also in certain general anesthesia cases, if we have to stand really very close to the fluoroscopy, then that should be our and we should be mounting all these safety gears to really prevent the risk of radiation is real, and a cumulative long-term exposure can cause very serious things. So we cannot disregard about the safety and radiation hazard in the process where a long term, when a long duration cath procedures are going on, the cath exposure, radiation exposure is really of a long. So how we measure this radiation exposure, I will like to highlight that those who are regularly and very often visiting places where there is a radiation exposure, they should think of putting dosimeter to calculate, which is like a badge as shown in the slide. We can wear it, uh, and this dosimeter gives us a cumulative radiation exposure dose, which we are having due to the repeated exposure to the cath lab. So those who work regularly in CT scans, these cath labs and radiology suits and interventional radiology places and these cardiac caths, they should, can't disregard for the radiation exposure because the safe normal background radiation which our sunlight gives us is about 0.5 millisieverts per year. So when we are and the maximum safe limit is about 20 millisieverts per year, and we can have this exposure over a period of 5 years with a maximum annual limit of 50 millisieverts. So 0.5 millisieverts per year anyway we are getting from sun exposure, but if our limit exceeds the maximum 50 millisieverts, then we can have this acute radiation hazard symptoms where from 0.25 to 1 millisieverts, we can have nauseating sensation, a loss of appetite. There can be bone marrow depression or lymph node affections. From 1 to 3 millisieverts exposure, cumulative exposure, we can have symptoms like severe nausea with affection of the spleen, lymph node, bone marrow, where we can really have aplasia or cytopenia, neutropenia, and when the exposure is more than 3 up to 6 millisieverts, then we can have this because of this neutropenia and all. We are repeatedly exposed to the infections. There could be unexplained diarrhea, the risk of sterility due to the childbearing age. It affects the ovum and the sperm's motility. So the risk of sterility is there. And if we are continuously getting exposed in this range, then there could be affection of skin in the form of skin peeling. If the exposure is more than 6 up to 10 millisieverts, then we can have a CNS impairment. And when the exposures are more than 20 millisieverts, death is so when but the risk of cumulative exposure, the risk of radiation is a real, and we have to protect ourselves before we try to rescue the critically ill patients. And so we should be always wearing all the possible safety gears, and we have to insist that they should be separately available to us, and not we are standing behind some other staff of the or the cardiologist and assume that we are protected, because it is a scattered radiation. And the walls and the screens and the shields, they really get scattered and then we get exposed. So we have to insist for the availability. They may availability of these safety gears to protect ourselves if we are repeatedly. Yeah, and there's long-term complications due to the direct exposure to the radiation. Is it can cause skin burns, thermal necrosis. If we don't wear goggle, then there could be early cataract formation, and excessive radiation can cause cancers of the brain, skin, and thyroid. And as far as thyroid gland is concerned, sometimes it's very difficult to have a symptomatic thyroid disease. So we have to really, those who work very often for a long duration in a cath lab, they have to get themselves tested for thyroid functions and thyroid gland examinations periodically. It is recommended to get tested thyroid functions and the thyroid gland periodically to rule out radiation changes in the thyroid gland. And also we see the people who work regularly in the cath labs have a higher rates of infertility and bone marrow depression. So a radiation risk which poses in the cath lab environment is real. So we have to keep in our mind about this danger. Also, another concern is about the, as this cath studies is a x-ray examination by a fluoroscopy machine, there is a lot of use of lot of contrast for the delineating of the structures like coronary arteries or any other vascular areas, or so they use dyes. So as shown in this slide, we can have two types of dyes, where ionic dye, which is a cheaper but has a very high chances of allergic reactions, and also it can cause vasodilatation, hypotension, ECG changes, and contrast induced nephropathy is a real concern in a patients who already have a compromised renal function. It is non-ionic contrast like iohexol, iopamidol, or ioxylal. They have less allergic reactions. They are more safe. They don't cause this vasodilatation or allergic reactions, and so they have a less nephrotoxic. So most of the patients, if they have a decreased renal function, we should really have to concentrate which dye in a what dosage, and what is the status of the hydration of this patient that we have to take into account. So we have to really use a patients who have a borderline renal function. We have to ask and consult cardiologist and explain them about the risk of contrast in this nephropathy, so they can limit the contrast dose. Then we can hydrate the patient adequately, and use of a non-ionic contrast should be required. Also, we can imagine why at all simple procedure like cath study need a presence of anesthesiologist, or why anesthesia will be needed. Because a cath lab is a varied environment, and a lot of from simple diagnostic angiographies to the excision of the aberrant pathways and electrophysiological studies, radio frequency ablations. So this is the spectrum of the cath lab, cardiac cath lab procedures, which can warrant supine position of the patient. Those patients may be having orthopnea, and they could be having heart failure. So they may found themselves very difficult to lie flat. So that will be the point where our role will start. So we will be really seeing cath lab patients who will be requiring supine position, and they need to cooperate with the request of the cardiologist about breath holding during certain delineation of certain structures. So there we have to on our toes to titrate what analgesics and what dose, what anxiolysis we are using, which will be covered in the next topic. So we have to be really, use our apply our mind, and that is why we have to be constantly in a communication with the cardiologist and ask about the expectations and our precise role in that particular patient management in the cath lab, what they expect from us. We really have to find out, and accordingly we have to choose our plan of anesthesia. Also, there are certain long duration cardiac procedures where immobility for longer period will be needed. Then we may use a go away straight away with a general anesthesia with a tube. Also, certain patients who, they will be anxious with the needle prick, and there can be a really pain when they are dilating or taking punctures, or dilating the percutaneous insertion of sheaths. And sometimes there could be ablation of radio frequency ablation of abnormal conduction pathways in case of recurrent ventricular tachycardia, ventricular fibrillation, or so in those patients, pain is real. So we will be called in to provide analgesia, which will not cause any effect on the. So these are a few scenarios which can really lead to our role. So we have to choose our anesthesia plan of anesthesia as per the need conveyed by the cardiologist. So our spectrum of role is from mere standby monitoring and acting only when needed, to monitored anesthesia care, to mild sedation with anxiolysis, to deep to very deep sedation, which can need to be converted into frank general anesthesia with or without endotracheal tube. So depending upon the spectrum of invasive procedure and the need and the type of patient, our role could be any of these. So when we are using for our role to make clear, when I say minimal sedation, patient will be always awake. So it will be just an anxiolysis in the form of injection midazolam, where patients can be made comfortable and they will be always responsive, and there is no effect on airway, spontaneous breathing, or any cardiac function. So mild to moderate sedation, the patients will be very calm, they will be breathing regularly, there is no effect of airway, they will be responsive with adequate spontaneous ventilation, and cardiovascular function will be not affected. In the deep sedation, or when we give general anesthesia, there we will need some sort of airway intervention with spontaneous or GA. There could be a controlled ventilation. There in deep or general anesthesia, there will be some affection of cardiovascular function. So when we use drugs like propofol, then we have to really think of what dosage we are using, because they can cause direct myocardial suppression, increase in systemic vascular resistance, a reduction in systemic vascular resistance, increase in pulmonary vascular resistance, which could be detrimental to the ongoing patients. So the usual medications we prefer. So this will be discussed more in detail in further slides. So we choose for anxiolysis midazolam. Sometimes our cardiologist colleague on the previous night, they give patients to diazepam. When we want to give analgesics, we should be using shorter acting analgesics like fentanyl in the form of 0.5 microgram to 1 microgram per kg, and we can titrate them every 30 minutes or 1 hour, depending upon the need. Because then if we use a really very high dose, or doses which are considered a normal, like 2 microgram per kg in a sicker patients, that dose also can cause tremendous tremendous effect on hemodynamics, and they can really need some intervention in the form of supporting ventilation. They may not help cardiologist in breath holding, and so the procedure So we have to, whenever we are using any anxiolytic or narcotic, we have to be, really titrating them to the effect or start with a smaller dose, take into consideration the duration of onset of action of these drugs, then the cumulative action, the total maximum action, and then accordingly, then we can, we really titrate. So smaller doses of fentanyl like 0.2, 0.3 microgram per kg, then we can titrate to 0.5, and we can repeat every 20-30 minutes as per need. And when we are giving was a deep sedation or a general anesthesia, then we can use, when the patient is hemodynamically unstable, then etomidate or ketamine is our choice for the induction. And when the hemodynamics are normal, or when we want to continue with a mild to moderate sedation, we can use a propofol in a smaller dose, probably in the range of 0.25, 0.5 milligram per kg, up to 1 milligram per kg. Dexmedetomidine again is a alpha 2 agonist which cause bradycardia and hypotension, has a lot of concern for use in a cath lab alone. So, but when we are dealing with a mild to moderate sedation along with ketamine in the mixture rightly mixed, then we can use it again like a titrated dosage. So these are the few commonly used sedatives and agent. And when we are using a frank general anesthesia in a pediatric cases or with a tube, then we prefer to use inhalational for maintenance once patient is so so as I mentioned in the previously, so we have to titrate the dose in the incremental doses of 0.5 to 1 every 3 to 5 minutes. Then again, the duration of effect will be up to 2 hours with a 2 to 4 hours post procedure. So we have to take into consideration the status. And so again, for fentanyl, we have to look for and gradual titration. So ketamine again, we have to use with as it cause minimal depression of respiratory effect. So propofol is considered ideal sedative with clear-headed recovery, but due to the decreased direct myocardial depression and raised decrease the SVR, it causes really hypotension. So we can't use higher doses. So we have to use smaller doses of propofol. So when we see the effect on the cardiovascular system of these commonly used agents, as I said, midazolam in a shorter dose don't cause, but when we combine midazolam and fentanyl, it causes bradycardia. Again, fentanyl is more cardiostable, so except bradycardia, it maintains contractility, SVR and PVR no effect, and blood pressure is also maintained. So ketamine again causes increase in heart rate, contractility, SVR, PVR, and blood pressure. So we have to really alone when we are using ketamine, it may cause trouble. So we have to always, combine it to the right effect where we want to offset. When we are combining it with midazolam or we are combining with fentanyl, then we can really take care of bradycardia with a positive effect on certain circulations like tetralogy of Fallot, where a rise in PVR is desirable, where we have to use, and a rise in SVR can cause a good circulation, pulmonary circulation, maintaining, preventing TED spells of ketamine. Again, here dexmedetomidine, no effect on contractility and SVR, a reduction in PVR and blood pressure with the bradycardia. So alone dexmedetomidine we cannot use in cath procedures. So, but when we are thinking of sedation and sedation or deep sedation, then it is recommended by law that a person who is trained in a basic life support and advanced cardiac life support. So a person who is giving mild sedation, ASA standards 212 statement says that non-anesthesiologist physician, so cardiologists themselves or a trained staff can sedate if they are trained in basic life support. A person who is certified in advanced cardiac life support can give moderate to deep sedation. So these are the recommendations about qualifications and requirements of a person who can really use what type of sedatives and what strength of sedatives for the procedure. Thank you.
Thank you, Rameshwar. Very nice talk on standby. Actually, this one is our in and out of on Cathlab, and a lot of will come after this. So next topic we will start immediately, I think.
Hello, Rameshwar. You will continue the slides. I'll
Yeah.
just
Yes, ma'am. I will continue sharing.
Yes. Yeah, coming to the common cath lab procedures and anesthesia concerns, I would again like to bring your attention to this fact that the patients who are suffering from cardiovascular diseases, they are the most sick patients, and that is the most common cause of death all over the world. We know that. And in cath lab, especially, they need our service because these patients, due to they're a very heterogeneous group of patients due to their age, their medical condition, and complexity of the procedure, and sometimes the length of the procedure and procedures. These patients demand our service for maintenance of airway. And actually, I want to bring one point here that always anything pertaining to cardiac problem, we require the support of cardiologists, but actually we only land up doing the most hemodynamic stabilizing part, as you all must have realized while providing this cath lab services. The airway becomes the first priority. We should never let go of the airway control throughout. So whatever anesthesia technique we use, we must have the knowledge of the hemodynamics of the patient suffering from the disease. As Dr. Rameshwar told about the pathophysiology of the patient is very important to know, because here we have very less time. We have to take very quick decisions. Next. No, please go to the previous one. First one. Yeah. So here the common procedures which are done in the cath lab are the diagnostic coronary arterial angiography, that is the bread and butter. And then, of course, the percutaneous intervention and coronary angioplasty. That is more riskier and more eventful than the coronary angiography procedures. Then balloon valvotomies and valve stents. And of course, nowadays, this TAVI, mitra clip, and pace, all these are being done for very sick patients who can't be operated for aortic and mitral valve diseases. Then pacemaker insertion and implantable cardiac defibrillator insertion is the main chunk. And nowadays, the electrophysiological studies are being done for the children and adults. So let's go to each one. Here we will examine the evidence-based practice. Go to the previous one, Rameshwar, the evidence-based practice. Here we will examine the evidence-based practice, which is being now being re-examined to be used in the practice services. What about the optimum duration of nail by mouth before this procedure? And the medications to be withheld before these procedures, such as oral hypoglycemic agents, the ACE, ARB inhibitors, and anticoagulants, and the state of allergy in the patients, which is documented in patients and the history elicited, like if they have selfish allergy or they are having food allergies, like they're atopic individuals. So whether they can develop an allergy to allergic reaction to contrast media or any subsequent problems to the stents, then they are often treated, pre-treated with the steroids and antihistaminics usually to prevent these allergic reactions. So let's take a look at really if it is really relevant to do that. So coming to the considerations regarding NBM, yeah, it is proven that it is better to keep them fasting than give them fasting of 2 hours clear liquid and 6 hours for solid, or like following light meal. That is really the right way to prevent any problems. No fasting is not preferred. And regarding continuing the oral hypoglycemic agent like metformin, which is a very common OHA drug, we have to continue treating with metformin pre and post procedures. No need to withhold it because apart from the patients who have severe renal dysfunction, only in them we can withhold. Rest of the population can receive it. So that is one thing for which we have got evidence. And the other one is about the insulin regimes. So the data is still insufficient, but it is not supposed to be withheld now. It has to be continued pre and post procedure. And the main decision regarding the ACE inhibitors and the ARB inhibitors, it is seen that if it is normal, the GFR is normal, then there is no need to hold it, and we can continue giving it pre and post procedure as per their doses regime. Only if it is less than 60 ml, then maybe we have to withhold. But the GFR is less than 60 ml. Regarding the oral anticoagulants, that is a main thing of concern because the risk of bleeding is there if the dosage is more, and then they become more unsafe or more risky, and thrombus and clot formation is there if it is not given. So it is seen that the evidence says that we have to continue the oral anticoagulants before this diagnostic procedure because they have this high risk of thrombotic complications. And when the cardiologist decides to use the transradial access also, they can be continued. There is no need to stop it. Then about the prophylactic anti-allergic pre-medication, it is not needed to be given like steroids and antihistaminics if the patient is giving history of allergy to shellfish, and it is not going to develop into an allergy to contrast agents because nowadays non-iodinated contrasts are being used, which has very low allergy ratio. And it is important to note that general atopy patients who are having history of atopy, that can increase the overall risk of other allergic reactions, including that to radio contrast agents. So in this group, we have to be a bit careful. Next, coming to oral anticoagulants before cardiac cath procedures. As you can see, if the patient is taking warfarin, then stop it 3 days before the procedure, because there we are looking for an INR of less than, if it is transfemoral, then less than 1.8 INR, and if it is transradial procedure, then less than 2.2 is okay. And then dabigatran should not be used in a very sick patient having a very low GFR. So the cardiac output really must be low to have this GFR. Then in that patient, we are not going to give dabigatran. Then rivaroxaban, apixaban, and edoxaban, they can just be stopped for 24 hours. Usually the cardiologist takes the decision about it, but we must also be aware about it. Next. Coming regarding the intra-procedure events or the procedures, what is the safe practice? It is, so we are providing sedation, anesthesia, and analgesia for the procedures. And at this time, we have to look at the access, which access the cardiologist is choosing, if he is going for the radial access or femoral artery puncture. If the cardiologist decides about femoral artery puncture going via standard access, or means puncturing blindly, or he's going through USG guided femoral access, then that really reduces the complication rate a lot, because the success rate at first attempt goes very high, and the time to access, number of attempts, then vascular complication in forms of hematoma, rupture, and access-sized hematoma, and increase and the chance of venipuncture. All these goes down drastically. So this USG guided access is really a boon. We should encourage our cardiologist colleagues to follow that. This is regarding the post-Cathlab procedure, post-procedure decisions regarding letting the patient having MRI examination, usually which they follow the procedure to check the stent, whether it should be done 4 to 6 weeks after the stent implantation. It is said that mostly nowadays the cardiac devices, including all commercially available coronary stents, they exhibit minimal or absent ferromagnetic property. So there is no point in withholding the MRI scan procedure and to wait for 4 to 6 weeks, because these ferromagnetic properties were there present in the early coronary stents, but nowadays it is not present. And then the chance of stent endothelialization is not present. And there is no hitting and tissue damages also due to strong magnetic field. So this we can let them have. Coming to the coronary angiography procedure, which is done in so many bulk, the patients are taken up in and out of cath lab. So here usually we give standby or monitored anesthesia care. And usually the cardiologist gives the local anesthesia infiltration at the site of any vein and arterial puncture site. And when we go as rescue anesthetist, if we are not present already in the cath lab, then usually we are called in there for any life-threatening events in the form of bradyarrhythmias, tachyarrhythmias, blocks, ventricular tachycardia, fibrillation, and sudden cardiac arrest. So we usually arrive there for resuscitation and CPCR. So this is just a clip. Just Ramesh.
Actually, I previously also I could not. I will. I'm how to.
Okay, Deepen can play it.
This is a clip. Actually.
Venipuncture happening there in the femoral axis. The radial puncture. Deepen, can you play?
Yes, ma'am. I will play.
Yeah, it was happening. Here they're introducing the catheter and the sheath, and they will reach at the coronary arteries, and they'll inject the dyes. Then they'll look at the screen to check for the blocks. So here, wherever you see the filling defect, that area is blocked area. Here in the left main below that in the LAD, there is a block. And then while when the contrast is getting delivered, and that time the patient can have events, cardiac events, like it can be arrhythmias, or it can be like patient can feel sudden vasodilatation and sense of uncomfortable, like pain in the chest, tightness in the chest also they have complained. So we have to just keep on reassuring. If we are there in the console far, we can come inside, or anticipating that before that also we can just give some light sedation in terms of midazolam or fentanyl. Yes, it has ended, I think. One more is, yeah. Yeah, coming to the percutaneous coronary interventions, here, as we know, the cardiologist requires us to give mild sedation before introducing the balloon. And here you can see in the cross-sectional, the guide wire is going beyond the plaque. Then the balloon is going above it, and the balloon is getting inflated, and the stent will be installed, and then it is withdrawn. So it can be through femoral artery, or it can be through radial artery. And at this time, usually we are called if certain cardiac events take place. And here, suppose the patient is not sedated, then the patient will be the patient moves. Then also it can give rise to problem. If the patient is over sedated also, that can also give the problem. And in the patient who is very much decompensated heart failure, having problems, then they also will not be able to lie down. So to keep them still, as Dr. Rameshwar explained all the doses and the combinations, we can, at that point, we can just give fentanyl or midazolam. Before we used to give actually cocktail, the combination of pethidine, Finargan, and that combination of lytic cocktail, it was being called. So there we used to take 50 milligram of each and then dilute. And then each ml we will again dilute to 10 ml, and then according to the body weight keep on giving 0.1 ml of that solution. So that keeps the patient very deep, and that used to give deep sedation and patient used to become immobile. So largactil, pethidine, and Finargan combination was that. Coming to the pediatric cardiac procedures, usually in the cath lab, they are taken the children who have congenital heart diseases, and they are different from adults because of their disease pattern and their requirements. And to them, GA is mandatory. And usually right heart catheterization is done to evaluate the shunt fraction and oxygenation, pulmonary vascular resistance, and the pressures in different chambers. And that time we have to ensure that the FiO2 is less than 25%, and the arterial saturation is when the arterial saturation is being checked, otherwise it interferes with the patient's values. And it's a very important step to remove all the air bubbles from the tubings that we have to take care, otherwise air embolization can take place. And we have to keep blood cross-matched, and blood products are to be reserved. Because in children, any untoward like it can rupture, can inside the chambers, or it can any untoward event can happen. So this precaution is always taken. And we give the combination of midazolam and fentanyl. And ketamine also can be used in these children. Usually they avoid it in tetralogy of Fallot and all, because the SVR, it can influence. It is said that it can influence the SVR. So we lose out on such a nice drug just because with ketamine we can achieve immobility, and with small dose we can get the child to lie down still and be in the state to do the shunt studies, the Cath sampling studies peacefully. So what we can do, we can combine inhalational agents with ketamine, and start with titrating doses from 0.03 to 0.05 milligram per kg, and then keep on increasing gradually. And with that, it is seen that the SVR doesn't get affected, along with sevoflurane if we use it. Or we can combine with midazolam, then that also midazolam and fentanyl, the standard doses, then that also can influence the interference with the SVR property of ketamine. But then we have to observe the children for little longer time, and then we must have naloxone with us in case the child or any adult also goes into respiratory depression. So that is a must to keep flumazenil and naloxone at hand. So coming to the percutaneous closure of septal defects, Here it is a must that it has to be a deep sedation only, and general anesthesia is given most commonly. Here the simultaneous use of TE is done, because without TE, this procedure cannot be done. And there is a risk of accidental extubation when TE is being used. And there can be arrhythmias, avid conduction defects, and device embolizations. They are the most common complications which are seen. And here also, we have to keep CP bypass standby and cardiac surgeon standby for any emergency happening. See here, when you go to you have a pointer, Rameshwar, just take it towards the equipment.
Is it visible?
Yes, yes. See, look at that. Look at that device. It is one disc. Then there are two discs, and it is loaded on a sheath or a guide wire. Then it is introduced from the RA to the LA. It goes to the defect in the septum. It sits there. Then it is put in place. And then here you can see in the fluoroscopy, there is this is the TE probe. The black one is the TE probe. And here it is the device, one balloon and two balloon. And when it is sitting in place, it is completely occluding it. In the TE also, you can see the chambers here in the RA. Then towards LA, now here it is completely sealing it. So you can see the continuous structure here on top of the RA. So this is the TE-based ASD closure, the device closure. Next. Here, the more commonly, the pacemaker insertion, usually done for complete heart block. It can happen in any age group. Usually the old patients, they come for it. Even in young patients having all this WPW syndrome or congenital heart block syndromes, they also can require it. Here we give them anesthesia with light sedation. Here the concerns are, we need two IV access, one for sedation, and the left cubital vein is specifically taken by cardiologist, where the contrast dye is administered to identify the subclavian vein and insertion of the pacemaker leads in RA or RV or IVS, wherever they want to put it. So here the most common complication is arrhythmias, followed by sometimes the perforation can happen due to the leads moving very close to the chamber wall. Next, here you can see the, we have to keep on the chest wall, the battery pocket has to be formed. So extra LA is injected here wherever they want to insert the pocket. Next.
Electrophysiology.
EPS studies where the mappings are done. Here you can see the islands on the left side. And here they are the round white ones are the ablated spots. So here, when we are giving anesthesia for standby for mapping studies, then we can use monitored anesthesia care. We have to sedate the patient properly, because here if the patient is requiring atrial fibrillation, patient is requiring radiofrequency ablation, then they require deep sedation. It's better to intubate them, because they can go repeatedly into ventricular tachycardia. And here many centers have done high frequency jet ventilation in these patients, because then there is no movement. The lung movements are minimized and chest wall movements are minimized, and that gives a better outcome. And here we have to remember that we can't use sympathomimetic drugs, and dexmedetomidine also is not used in this patient, as it interferes with the mapping procedure. Next. Coming to the ICD placement, here most commonly general anesthesia is given. This can be placed percutaneously under mild to moderate sedation. But when the device is to be tested, then that needs a deep sedation. So usually it's better to do under GA. And these patients are sick and they have a lot of comorbidities. So they can put the lead in the right atrium or in the right ventricle or in the... And this is the CRT device. And here there is a real risk of cardiac perforation, MI, stroke, and pneumothorax. because they go through the subclavian vein. Next. Coming to the balloon valvulotomies, most commonly mitral valvulotomy is done. Here the anesthesia concerns are when the balloon is going, the RA towards the mitral valve it is going, then the here you can see the balloon is going, and here it is single, and here it becomes double, and then it becomes continuous, and they keep it inflated almost for 8 seconds when there is no flow. When there is no flow happening, then we have to maintain the preload. We have to fasten up the fluids, and we have to use vasopressors, and we have to heparinize the patient, and we have to maintain the SCT 100 to 200. And in this state of no output during this balloon dilatation, we have to be very alert. And if there is any damage, any complication happens, then immediately moderate to severe MR happens, and that requires mitral valve replacement. And so that's why always the BMV procedure needs a standby from CVTS surgeon and the cardiovascular OT. This case we will discuss later on. Dr. Tejaswini will discuss about it. But we have to keep on looking at all these symptoms of decreased consciousness, hypotension, and sudden onset pulmonary edema. So these are the procedures usually we encounter in Cathlab. Coming to the mitra clip and TAVI, these are the new procedures here in. These are the replacement for mitral valve replacement patients who cannot undergo mitral valve replacement. In them, the annulus is just shortened down. See, the clip is being introduced here, and then the annulus is being, the white thing you look at, it is tightening the annulus. So the regurgitant, this becomes less, the area is becoming less here. And here, in this TAVI procedure, this is transventricular aortic, this is aorta. It goes from the femoral artery to aorta, then it goes to close to the aortic valve. Then the patient remains heparinized, and then they fibrillate, and then they put the device there. So here we have to give GA, and the pacemaker port has to be used through the right IJV. And usually they go from the radial artery. So these patients, they require full general anesthesia. So these are the advanced techniques. So this is a possibility, like when the cardiologist evolves in your area, then we have to also be at par with their technical efficiency. So, so what are we looking at in the Cathlab? What are the common complications which we have to treat? So it can be air embolism, it can be arrhythmia in the form of brady and tachyarrhythmias, thrombus formation on the device applicator and embolization of that material, stuck guide wire, stuck devices. Means the cardiologist can't deflate the guide wire balloon after inflating it, or the guide wire also can get stuck in the chambers or in the cardiac tissues. Then pericardial hemorrhage and tamponade. Then hypotension or hypertension also sometimes happens when there is severe sympathomimetic response and the patient is not very much under. And bradycardia, tachycardia risk is always there throughout the procedure. And if there is major vessel injury, then there is hypovolemic shock, and sudden cardiac arrest can happen anytime. Of course, anaphylactoid reactions to the contrast dye is a possibility still, and to the stent also, after putting the stent also. So now go to the case scenario. Yeah.
Good evening, everyone. I'm Dr. Tejaswini, working as a senior resident in Nair Hospital along with Dr. Lipika Madam and Dr. Rameshwar sir. I would like to present a case which has happened in the anesthesia cath lab during it's just a scenario which is just like 15 days back, wherein we will again take you a journey from the cath lab to the cardiac theatre. So how was the scenario and how do we like to go? So from anesthesia standpoint and beyond. So here is a 26-year-old female who was a known case of rheumatic heart disease, presenting with severe mitral stenosis, who was posted for BMV in a cath lab. Our trauma team, received a distress call from the cath lab for resuscitation of the patient with a complicated BMV. So what was the differential going behind our mind at that moment of time? Is it a hypotension with pulmonary edema with unconsciousness that is demanding our treatment at that moment of time? Or is it a stroke? Or it is a complete cardiac arrest patient where we need to go and resuscitate for the further management? Or it is just cardiac perforation leading to tamponade, hence needing a re-exploration in the cardiac theater? Or it is a rupture of the chordae or a papillary muscle needing an urgent mitral valve replacement. So by the time before we reach, what was the role of the cardiologist when they suspected it to be a tamponade? So cardiologist had already accessed both the femoral and artery vein before starting a BMV procedure. By the time they suspected tamponade, the hemodynamic condition was stabilized by the cardiologist by inserting a pigtail into pericardial cavity, because they take a nick in the level of the Zipfi sternum, wherein they go just by 2 centimeters in, directing the needle to the left side of the shoulder, hence by which you can direct the pigtail and directly you can aspirate the blood if you are suspecting a pericardial tamponade. So the same thing was done because they could see it lively on the cath lab, where the heart was getting pushed up and the rest of the mediastinum was getting completely pulled up with the blood. So they continued with the pericardiocentesis, and the blood which was coming from the pigtail was used for autotransfusion. The autotransfusion here is quite different from what we do in a routine cardiac OT theater. Here, what was autotransfusion for them? To resuscitate a patient. Basically, the blood which is obtained from the pigtail, before you obtain the blood, we will always heparinize the patient. So this patient was adequately heparinized, sepsis maintained throughout the procedure. The blood obtained from the pericardial pigtail was given into systemic circulation. In the systemic circulation, basically we are meaning here femoral vein, which was the biggest one of the vein that was available for them handy and was used for the better outcome of the patient. Simultaneously, this was not only sufficient for the patient, they had to start the inotropic support and NORAD, inotropic and the vasopressor support throughout. So they thought the patient will require an urgent CVTS exploration for the cardiac tamponade and hence assessed further. So what is autotransfusion? This autotransfusion, what I'll be speaking, is completely different from what we had done in a cardiac cath lab. Autotransfusion in a CVTS theater basically means what the blood is shed in the cardiac field or in the operative field will be taken back and it will be run into some automated machines. So one of the example is a cell saver, wherein the blood which is sucked from the operative field run into a machine, then afterwards it is centrifuged. So basically the RBCs which are there, the RBCs are washed with a normal saline. They're concentrated to approximate of 25 ml, making a hematocrit value of about 55%. So the entire aim is not about the volume when we are saying about autotransfusion. The entire aim will be about the hematocrit, what we are trying to maintain throughout. So it is about 55%, about 225 ml of the volume what we obtain during this procedures. So these RBCs which we obtain are directly transfused into the patient, or they will be washed again repeatedly and then stored. So if the unit is stored, how it can be stored? It can be stored at room temperature for all about 6 hours, but you want to store it for next 24 hours. Then it has to be cooled and kept in the fridge at 1 to 6 degrees centigrade. And it has to be used only within 24 hours. In which conditions we are not using the cell saver blood? It is basically in a patients who are having malignant neoplasm. For example, if a patient is having a breast carcinoma and she is coming for CABG, even though she is post breast carcinoma, she's still in the phase of that. So we are quite dicey whether to be used or not used. So in such conditions, we are trying to avoid. So it's a malignant neoplasm, or patient is if having any active infections, or if it is a contaminated operative field. Imagine madam has already told about some of the advanced techniques like TAVI and mitra clip. TAVI and mitra clip are such kind of a procedures wherein the patients who are more fragile, who cannot handle the surgical stress, are usually posted for it. These procedures are always high-end procedures and they are very much costly also. One mitra clip or one TAVI can go lakhs together for a patient. At this moment of time, the tissues are so friable, they may not even hold this procedure. At that moment, if this TAVI or a mitra clip fails, these patients are immediately moved into the theater, there wherein the patient can have a tamponade. At such kind of condition, if we use this kind of blood, this is not going to help the patient. That is what we are telling, the operative field has to be a better one. The only disadvantage of this procedure is the lower percentages of RBCs are covered than in the pre-operative autologous donation. Pre-operative autologous donation, you have already seen wherein Jehovah's Witness, we put a 16 gauge IV needle and then take the blood, keep it in line and then give the patient whenever required. So this auto transfusion can be done by 3 systems. It can be inline, self filling or continuous. Inline, which involves using a blood bag that collects the fluid for a later use. Self filling utilizes a vacuum to help improve the flow of the blood into the bag. Continuous uses an infusion pump and a filter to directly place the blood into patient venous axis. Here the filter is always attached in any of the auto transfusion machine, because whatever the operative field has n number of debris, because it included debris from the sternotomy, which could be a bone marrow or a bone piece, or it could be just a fat. If this gets into the circulation, then the patient can have embolism, because of which can go into your central circulation, basically your brain. So we are worried about this. So hence a filter makes an important scenario in these cases. So what was the scenario when we our team got a call for attending the cath lab? So what were the vitals, what could we see? GCS of the patient clearly 15/15, heart rate was around 110 per minute. Blood pressure was maintained 100/60 millimeters of mercury with injection noradrenaline going at a rate of 1 mics per kg per minute, along with auto transfusion being done by the cardiologist. Saturation was 100%, which was over a polymask at 15 liters per minute of O2 without any respiratory distress, accessory muscles, and there were no crepitations or auscultation. Again, ruling out the patient is not in pulmonary edema, or it is because of most of the time when we think it is a call because of BMV, we always have a mind behind that. Most common thing what we expect is it's a failed BMV leading to severe MR. So we may need to take the patient for mitral valve replacement. This is what the thing. So whenever they are coming, they come with the presentation of sudden unconsciousness, hypotension, pulmonary edema. So that was the things this was already ruled out. So what was the plan we had put behind our map? So it was planned for emergency cardiac exploration. Hence, the patient was electively intubated with controlled ventilation under mild sedation, along with injection etomidate 10 mg, fentanyl 50 mics, and scoline by 50 mg. When intubation was going on simultaneously, our juniors helped us to inform the cardiac surgeons and the team in the cardiac theater, basically our anesthesiologist, for the preparation of the theater, wherein we had already sent a call for blood bank for issuing 4 pints of PCV along with 4 pints of FFP. So how was our journey from cath lab to the cardiac theater? So basically, we continued the mechanical ventilation, as we are very much helpful to the Naya hospital by saying we have a portable ventilator along with this. And we continued our inotropic support with vasopressors and IV fluids. Auto transfusion was continued by the cardiologist from the cath lab till we reached the CVTS OT and till the sternotomy was done. This was made sure that the patient will receive the blood, whatever was coming in the pigtail, because if we lose this blood, then the patient can collapse at any moment of time. So this auto transfusion here makes a very important logo to save a patient. There are n number of chances when we fail to do this procedure. We have seen the patient can be lost just from the road to cath lab to the cardiac theater. So it is very, very important step where we continue the auto transfusion and do not stop the auto transfusion till we do a sternotomy and see where exactly the pathology lies. All the resuscitation equipments also were carried along with us during transportation of the patient. So once we arrived in the cardiac theater, we handed over the case to cardiac anesthesiologist team. All the monitors were attached, which include all our pulse ox, then ECG, rest all, NMT, then entropy also. Femoral arterial line was already taken in the cath lab. So hence this line was transduced for monitoring the invasive BP. And patient was put on general anesthesia and put on mechanical ventilation. we know as we were giving the supports to the right femoral vein, simultaneously we planned to shift the supports to the right IJV because we wanted it to be more handy. Hence, we secured an immediately right IJV. I think within some hardly some 2 minutes, not more than that also. And inotropes were continued for this axis. All this time, autotransmission was ensured by the cardiologist. Then they painted the patient, draped and ready for sternotomy by the CVT surgeons. So once the sternotomy was done with utmost care and all the supports and autotransfusion, cardiac rent was found at the IVC and RA junction. The basic thing what was happened is when the catheter and along the guide wire has been passed, when they were about to take a posterior turn, they actually hooked around the IVC RA junction, which led to the tear in the IVC RA. Hence, the patient went into immediate cardiac tamponade. So this was notified, rectified and repaired and was also informed to the cardiologist because the cardiologists were throughout to see where exactly they had also gone wrong. Then the patient was shifted to the intensive cardiac care unit with the inotropic support, mechanical ventilatory support. We had already, as we had issued already for FFP and PCV, we planned to give the PCV and FFP transfusion to patient and we tapered off the inotropic support very gradually. The next day we had extubated the patient because patient was completely holding the hemodynamics, no inotropic supports or vasopressor supports. Patient was completely conscious, oriented, time, place person with GCS of 15/15. Hence, we extubated. After extubation, within like 2 hours, the patient was given orals. Patient had already started doing well. The next day, when we followed up the patient for the second day, the patient was doing well with the incentives also. So this patient, even though she was posted for BMV, she did not have a complication which is more common, that is severe MR. She did not present with that. She was like something out of the object or out of a town thing she presented to us. Hence, this was a very unique scenario that has actually happened and we could actually rectify that thing on the table and then save the patient. So this was a combined effort which was taken by the cardiologist, the anesthesia team and the surgeon, and hence the patient also went home happily. Because she was just a young patient who was just 26-year-old with 2 kids already. Before this condition was not diagnosed and she was like delivered normally also with vaginal delivery wherever she has delivered. So what are the Cathlab procedures which are demanding the cardiac surgeons and the anesthesiologists to be a standby? So whenever a patient who is posted for high-risk BMV or a patient who's been stuck with a guide wire during angioplasty, this is a very common scenario, especially when the guide wire gets hooked into the RCC, in the RCA when they are putting the guide wire. This often happens, which needs an again exploration. Failed PTCA, again demanding an emergency CABG. If a patient who is having a left main around 70% with a LAD 100%, with a PLV also involvement, and now he's been taken for PTCA and this fails, the stent fails to open or deploy, then his patient, if he's not holding on with the hemodynamics, if this emergency needs an emergency CABG to be done. So in these conditions also, we are supposed to be always on our tip of toes and take care of the condition. Or there is a rupture of coronary vessels during angioplasty, or it could be a failed TAVI or mitrectomy, as I've already told you. We are always on standby whenever a patient has been posted for a TAVI or a mitrectomy procedure. Or it could be a cardiac perforation leading during a pacemaker lead placement. Because these leads are quite sharp and whenever they are placed within the endocardium, they have to be screwed. And the screwing, only the cardiologist will be able to understand how many screws have to be screwed properly, along with the help of the company people. So if this fails by any chance, then the patient can immediately have a myocardial perforation, which can be a hazardous complication to deal both for the anesthesiologist and the cardiologist and the CTVS surgeons also. Or it could be a failed septal closure device placement. Okay, wherever when we are not able to close the rims of the ESD, then again we may need, will be needing help for the cardiologist to do the procedure. So what is the conclusion we are obtaining from learning how the cardiac setup was done, basically how the Cathlab setup is done and how the anesthesiologists have faced the challenges and how do we adapt ourselves, followed by what are the routine procedures we commonly do and what are the out of box procedures we do, and what happens if we face an emergency such kind of like this, we expect something and then comes out something. So what's the conclusion? So number of procedures and its associated complication are increasing worse because of the complexity of the procedures which are associated in the Cathlab. and the interventions are done on the more sick, the old fragile patients are increasing because the cardiac care what is being given in the last 20 years has been gradually shifted to a very large scale, and hence the door to balloon time what we usually call that was initially 90 minutes now reduced to 45 to 60 minutes. So this makes us to be always like be ready for anything at any moment of time. We are on call for next 24 into 7 hours and helping the patient at every moment. So it's just a teamwork by all of us. So role of anesthesiologist is being more challenging in changing environment with this sick and debilitated patients. And by training and literature study, one can provide anesthesia services. It doesn't mean everyone has to, no one can give, I mean like, this is being a part of the studies wherein even our students like residents are being trained in the cath lab so that they are more comfortable even when they pass out as MD and can do the procedures. And communication and planning with the cardiologist is always a must because it's a remote location and we should be always knowing what all things are there and how we need help. So we should be aware about it. These are the references for our entire presentation. Thank you.
Very nice presentation, Tejaswini.
Thank you.
I'm really thankful to Vitika ma'am. And this evening, she only not herself presented the case, and but today with Rameshwar and Tejaswini presented the case. This is the what I can say the generosity of the today's teachers. They introduce in today's era to work hard, face the challenges, and do the case meets or even presentation like this. It's a private forum part of the case meets we started when in ICC to provide the insights of private practitioners problems with stalwarts. And today's in and out almost Cathlab is we studied a lot, but some lacunae was there, and you did a lot of work in Cathlabs. And most of our queries are solved today. Thank you, ma'am. Especially to you and Rameshwar, really hats off you, even Tejaswini also. Today we will take questions from audience. Two questions are there. First one is Mr. Avino Mohan. He's asking, please also kindly elaborate and mention about interventional radiology, MAC, PAC, anesthesia, standby, and beyond for our interventional radiology procedures with regards Dr. Avino, interventional radiologist.
Hello, Tejaswini. I think you have to mute yourself. Tejaswini. Hello, Sachin.
Yes, Rameshwar, please.
Hello, I think Lipika madam will take this question or I will answer. Hello, madam.
No, I didn't hear.
Yes, yes.
I could not hear.
Okay.
What's the question?
Yes, please, Rameshwar, you can.
Yes. So the question is about interventional radiology, monitored anesthesia care, PSC, anesthesia standby and beyond. So actually nowadays the structure of interventional radiology or interventional neuroradiology, or where we call DSC or this the challenges remains the same of non-operating room anesthesia. Nowadays we can have a hybrid operation theaters where the these minimally invasive interventions are done, and they are if something goes wrong or to support, or sometimes when we are doing an open procedure we may need to go to minimally invasive to look into more smaller structures. So the challenges and assessments and most of the things are same as of operation theater, and all about optimization and when mostly the diagnostic procedures of these interventional radiologies are done under this local infiltration or mild sedation, and most of their neuro-interventional neuroradiological procedures need absolute general anesthesia with endotracheal intubation, because most of the time they need controlled ventilation and apnea or absolute immobility to come to the definitive diagnosis. So when absolute immobility is required, we have to go for endotracheal intubation with a general anesthesia with a muscle relaxant. And when we are doing other interventional radiology procedures like this mm, diagnosis or some peripheral vascular disease catheterization or diagnostic interventions, then probably the same spectrum of mild to moderate sedation with a pain relief, the same principles of a cath lab anesthesia we have to follow in these new interventional radiology suits also, because the atmosphere remains the same. The challenges faced by the anesthesiologist are like a non-operating room anesthesia. I think this will be hopeful, or if madam wants to add something.
Yeah, here I want to add that the use of the contrast is the biggest difference in cardiology practices and in neuro anesthesia. The incidences have come down, but still it is happening when they are going for different kind of dyes which are having very complex chemicals. There the risk of anaphylaxis is very real, and actually there is no way of knowing it before. So history taking is a must, and being prepared for it, and doing the follow up for the patient, because usually the from the creatinine value also we can make out, like even though immediately no damage is being known, then later on the kidney can suffer. So by we can do our bit by maintaining the patient well hydrated before and after, and advising a creatinine value later on, so that the eGFR can be calculated and the AKI can be made out if it has happened, because otherwise the patients go home and they later on they go into the assault is already done, and that we have to take care, like as a part of the team we should sensitize and keep in mind, I think.
Thank you, ma'am. I think this question is well answered by ma'am and Ramesh also. On my part, maybe there is noise somewhat because of festival season. Maybe
Yeah.
that's the reason a lot of noise is there. But
Yes.
still, we will managing somehow.
Yes.
So I
Yes.
think on Cathlab point of view, almost all queries are resolved. So in question box, no questions from audiences, because almost very clearly you mentioned about the problems with the cath labs. I want to one single question asked to Rameshwar. I want to ask which drug you are using nowadays for cath lab standby or for sedation purpose point of view? Midas, fentanyl, or Dexmed, ketamine. What fix combination you are doing?
See, most of the time when we are asked for sedation, we are asked for these pacemaker insertions or patients where they want to do some intervention. So these are some ASD device closure, or in a really pediatric patients, 2-year-old, 3-year-old, where they this device closure warrants absolute immobility. And nowadays we are using TEE for confirmation of correct placement of A. So where a fluoroscopic confirmation is done, you may go with a deep sedation without endotracheal tube in pediatric patient for device closure also. But as the TE warrants us to secure airway, because the probe is really, they put and maneuver. So nowadays, previously, when we were not having TE, we were using deep sedation or this propofol and fentanyl along with midazolam, and then small dose of ketamine in a pediatric patient for device closure, is titrated doses, and deep sedation, where sometimes intermittent controlled ventilation also to ensure immobility. But nowadays, for placement of TE and all, from the beginning only, we plan with a general anesthesia with an endotracheal tube. Also, where we are putting a pacemaker in adult patients, and really they are sick, and it takes around 2 to 3 hours in our setup. So we need to give them sedatives. Then we prefer to give them a combination of midazolam, probably 0.5 to 1 mg titrated every half an hour or 1 hour, and then fentanyl in analgesic doses of 0.5 to 1 microgram, which we can repeat after every 30 minutes, along with a copious liberal local infiltration as they continue with the procedure. So that is how we proceed for adult patients for pacemaker insertion. And these BMVs and other diagnostic procedures in adults, mostly we use only we are there to manage if something goes wrong. So that's how, because the cardiologists with their 2D echo evaluation, they are always aware what will in which cases the things will go wrong, in a what way. So they prefer our presence beforehand. So when they call us before starting the procedure, that is the time when we have to recognize that this is not a routine BMV, or this is not a routine procedure. So they expect something to go somewhere wrong. So we have to really discuss the ecography report and what is their problems they can have in maneuvering the walls and friable. Then there can really be a stroke. There are few incidences where local BMVs they were doing under local, and after the balloon is the walls are this balloon is inflated and they made it dilate. Then there is these vegetations are getting into the systemic circulation, and patients are having on-table stroke due to these vegetations causing brain obstruction in the circulation. So that is how we are changing because of the complexity of procedures they are handling. So the anesthesia principles remains the same, but what they are planning and what they are expecting from us, that clear communication will make a lot of difference in choosing the correct plan of anesthesia. Thank you.
One question in the chat box. Mr. Mohan Patak is asking, is cardiac OT is must along with cath lab?
I think Lipika madam will answer this question.
Yeah, I would like to answer this because we have done extensive this literature search on this, and it is seen that as the cardiology practice has evolved and most of the cardiologists are doing angiography and angioplasty left and right, and they have increased their competency, like they're technically also, they are not failing. It is advisable that at least they are recommending, like there was a very large study including multiple centers in US by a Texas center. They had done that because US being a developed country, they are not having, like everywhere, they are not having a cardiac OT attached to the cath lab. So what they concluded that they took multiple data from very over a long time and multiple cases. And then they recommend that if the ground ambulance can take the patient within 1 hour to an apex referral center where the access to the cardiac surgery theater and cardiac surgeons are there, then it is okay to conduct the cath lab procedure. So that much communication should be there beforehand, whoever is practicing, the cardiologists and the anesthesiologist as a team, because now it has become mandatory to have BLS certification proper by American Heart Association courses. Whoever has the BLS certification can give mild sedation like midazolam. And whoever has got advanced cardiac life support training and certificate, which is getting updated over 3 years, then they can provide deep sedation. That is the scenario now, which is being followed, I think, in Maharashtra properly. Yeah, I hope you get the answer.
Yes, ma'am. It's a right answer you gave to Dr. Mohan Patak, sir. So I feel no questions in question box. Uh, I wanna ask one related to that Dexcate combination. Will you using Rameshwar in your practice?
Yes, yes. We are using actually the known dose of dexmedetomidine alone we are not using, but a smaller dose in the form of a 10 microgram dexmedetomidine with a 10 milligram ketamine concentration made in a 10 cc syringe, and then we can use a smaller small dose of 0.2 microgram per kg and 0.2 milligram per kg of ketamine in incremental doses. So they offset each other's adverse effects, and it really gives us, when there is no requirement of controlled ventilation, then we can go for, and we really have to look for what changes we are seeing on the screen. And in a combination, they are good. If we use them alone, then they cause a lot of hemodynamic disturbances. So we can use them, and we are using them.
So you are using 1:1 ratio, not a 1:2 in pediatric. Last time Pali also mentioned about 1:2 like ratio they are using for their surgery procedures.
Here we have access to the fentanyl, so we anyway we are using it in a 0.5 to 1 microgram before giving anything to make him so as we are using fentanyl, we are restricting ketamine to so fentanyl is always there.
Okay. So you use Dexcate with fentanyl like combinations.
Yes, yes.
Okay. Thank you, team Cathlab. I can say to all of you, because everything was related to Cathlab, and ma'am is always great. She spoke on in depth on any topic whenever we can ask her. So this one is the example I can say to audiences. Ma'am, very much thank you to you. Rameshwar, thank you. Tejaswani ma'am also. I'm very much thankful to you from ISS City branch, Nanded, that you are part of this case meet marathon we are conducting, and I'm really appreciated your work, and you came on our short notice to with and in all this case meet I can say I'm really proud of you as a narrate from my side.
I thank a lot to you, Sachin. You have done a great job in ISA. We want a photograph with all of you. Ask the pen to take with President Sir.
Dipen, please share with me one photo during the course and share with me. I will share with ma'am.
Yeah, with Ramesh.
Yes.
And your branch.
I think our president might be left. Yeah.
He is left. Okay, with you is okay.
I think, yeah. Dipen, hello. He will share, ma'am, because he's even running video also. He can do that, and I will share with you.
Yeah.
So I think I will conclude.
Next case study.
I will share. Yes.
Thank you.
So I will conclude this session with the note that we will meet in next week with ma'am same obstetric anesthesia, distress and stress of anesthesiologist. So this one is the topic like obstetric stress and distressing anesthesiologist, that tips and tricks madam will share with us in next Friday 8 p.m. So don't miss the next meet. Thank you, ma'am. I will conclude this session from now.
Yeah. Thank you, Dr. Sachin.
Thank you.
Thank you, Ramesh.
Yeah, good.